Then they're trying to add the PJB because the PJB is the easy one for the sleep plus. But I must say that we need the long-term follow-up, because when we follow up the patient that I do the sleep plus, now the outcome is quite the same with the sleep, I must say. And if you need to do so, the studies is quite hard for you, and you need to research more, or you need to practice more until you quite comfortable with the technically. So you can learn more from our speakers for today.
Thank you. So our next speaker is Dr. Pontep Pathanwani, the bariatric surgeon and MIS surgeon at Nangsi Hospital from Bangkok. His topic today is focus on the outcome. Is it comparable, and a discussion on comorbidity of the nutrition and nutritional long-term outcome. Please welcome.
Thank you. Thank you. Good morning, everyone. Good morning, Professor Cole. Thank you, TSMBS organizing committee for giving me a great opportunity here. So the next topic is about other outcome comparable between bypass and sleep plus procedure. So these are all the obesity treatment in the world. We know that the surgery is still most effective of obesity treatment, and sleep plus procedure is here. So you can see the trend of the sleep gastrectomy is increasing nowadays, almost 60%. And they beat the bypass in 2013, but you have to aware the revision surgery is also increasing the number up to 16%. And a lot of papers show that in, especially in the supermorbid obesity, gastric bypass more effective in 1 year. This paper includes almost 50,000 cases of supermorbid obesity. They conclude that for this group of patients, they favor the gastric bypass more than sleep gastrectomy. So let's see the long-term effect of the sleep gastrectomy for the 10 years. They found that percent of excess BMI loss about 50% and significant improvement of comorbidity. But you can see the diabetes remission about 60% and recurrence about up to 40%. And some renal GERD up to 32%, and reoperation and conversion up to 20%. This is a big multi-center RCT sleep bypass. Compare long-term effect between sleep gastrectomy and gastric bypass in severe obesity patient. The number is about 300 cases on each. BMI about 43. You can see for the first year, it look compatible between sleep gastrectomy and gastric bypass. But we need to more follow up to 5 years. You can see the significant change, higher total weight loss percent in gastric bypass. So what happened? We have to know the mechanism. Gastric bypass increase the GLP-1 and peptide YY from the high gut hypothesis. So GLP-1 is secrete from the distal iron and increasing insulin sensitivity. This balance when you eat the food, increased insulin sensitivity. But if the nutrient pass the duodenum, it's gonna secrete the anti-incretin to balance. If you have more anti-incretin level, you're gonna have the type 2 diabetes with the insulin resistance. So that's why long-wide gastric bypass, they have two mechanisms to beat the diabetes. Bypass the nutrient from duodenum, so anti-incretin is decreased, and let the nutrient to the iron, so increasing GLP-1. But for the gastric bypass long load from 30 years, that's why the number is going down to 17%. Because we found some problem like marginal ulcer, dumping syndrome, internal hernia, anemia, vitamin deficiency, especially in Asia, they have the high level of the gastric cancer. So that's why in Asia Pacific create a new procedure, this sleep plus procedure. This Monument Valley. I said. So the sleep plus procedure is a new procedure at intestinal bypass to sleep gastrectomy. So it's simple and has physiologic advantage of the gastric bypass, but minimize the adverse effects. So the earliest sleep plus procedure is BPDPS, and after that, many of the sleep plus procedure were patterned after BPDPS. So it's happened in 1986, like this. So you can see the common channel is about 1 meter, and air limit 150. This sleep gastrectomy, but use the more bigger bougie up to 50. You can see BPD-DS compared with BPD. The common channel in BPD is like a 50 centimeter, so it's more protein malnutrition. The common channel in BPD-DS is 1 meter. Common sleep plus procedure in Asia Pacific is SADIs, sleep DJB, PJB. So let's see the SADIs that approved in the US by FDS. So they're gonna fix the duodenal idle limb to 50 cm. So this common channel. Before that, they used 200, and the patient have protein malnutrition, so switch to about 250 centimeter. You can see compare BPD-DS, the same sleep gastrectomy, this single anastomosis, and common channel 250, but for this is 1 meter. Okay. About the sleep DJB, prescribed by Professor Kasama for the Luong Y, and for the loop technique by Dr. Wong. This Luong Y DJB, the loop limit is 150 cm, and the BP limit 1 meter. So Professor Kasama published a 5-year result of the sleep DJB with the type 2 diabetes. Is good. A1C is going down from 8.9 to 5.8, and follow up to 5 years, the diabetic remission up to 60%, and the percent of total weight loss up to 30% at 5 years. So they conclude that this technique may be equivalent with the gastric bypass, but need long-term follow-up. Let's see the loop DJB. So the principle, they fix the BP limb 2 meter. This from the paper, so the fellow can see standardized from SNBS technique. But we don't know about the common limb. Okay. So what the importance of the common limb? So let's see this paper, revision surgery of malnutrition after SADIs. So initial common channel length was 2 meter, but the patient have the malnutrition, so they elongate to up to 3 meter. So many literature show me that in any case, at least 3 meter of the small bowel should always remain in the food stream to prevent the protein malnutrition, vitamin deficiency. This paper from Thai Professor Walut to measure the length of the small bowel in Thai patient who underwent the elective open laparotomy. So the number is about 48 cases. You can see the length is from 169 to 7 meter. The mean is 4 meter, and not 11 with the BMI of 9. This all the literature about the total small bowel length is about 3.6 meter to 5 meter. So let's see, SADIs compared with the loop DJB. So suddenly fixed duodenal idle limb to 50. If the patient have for 50 centimeter, they're gonna have 2 meter BP limb. About the loop DJB, fixed BP limb 2 meter. So the common channel will left 250. So it's the same. If the patient have about 450 centimeter small bowel length. But if the patient have 7 meter of the small bowel length, it's different. That's why studies can have more effective control the body weight because they fix the common channel at 250. And what happens if the patient have 350 centimeter for the loop DJB? They can have common channel only 150, so have to be careful. That's why I discussed with Professor Wong, and he encouraged to measure the small bowel length in every cases will undergo sleep plus procedure. So the more simple is sleep plus PJB. Professor Wong published first HCS series about 65 cases. So BMI going down, A1C going down, but still be careful about the common channel. So I'm doing right now with the research about the total small bowel length measurement in Thai morbidly obese patient. So I have operated reliability test. So I count the pig intestine and let the observer measure 1 meter, 2 meter, and I found that I do less than 10% error. So this is the real one. So in my series right now, but not yet, not complete yet, I found my patient have total small bowel length about 460 to 760 centimeters. So this one is a real patient. This pig intestine. So let's see, if we not count measure the small bowel length, we fix from leafletter 3 meter blind loop for the PJB. If the patient have 460 centimeter, they're gonna have common channel only 140 centimeter. That's a problem. Okay, but I call the Taylor sleep PJB with the measure total small bowel length. I fix the common channel at 3 meter. I count the total small bowel. It takes time about 10 minutes. And tailor the blind loop depending on the small bowel length. So the patient will not have the malnutrition. So this example of my patient, BMI 53, body weight 165 kg. So first, try to find the DJ junction. So the position is very important. Let the head down a little bit, and have to be careful to traction the huge momentum because it can make bleeding. And let assistant grasp the reserve colon. And for the landmark is IMV. So continue measure. Going down to DJ junction to IC wall. Going down. So 1 meter. Going down 740 centimeter. uh, 760 centimeter. And then I make BP 50 centimeter. And I calculate, so blind loop is about 410 to have the common channel 3 meter. So I'm gonna fix common channel at 3 meter and blind loop about 410 for this patient. So this is my example of my patient who underwent the sleep plus PJB. So I compare my sleep gastrectomy, 53 cases, and sleep plus BMI about 43 and 41. So it's look compatible at the first 6 months, but at 1 year you can see significant higher 12% total body weight loss, 45% in sleep plus. And also A1C is going down but not significant. We need more number. And no perioperative complication, no protein malnutrition, no diarrhea, no anemia, all vitamin is good. And this paper present short-term outcome also about 1 year compare sleep gastrectomy and sleep gastric bypass. So it's look sleep PJB is good compared with the sleep gastrectomy and bypass and less malnutrition and or vitamin deficiency. But some growth is happening. So this is a big meta-analysis in 2021 compare the sleep gastrectomy with all the sleep plus DJB, PJB and studies. They found that significant greater weight loss with sleep plus than gastric bypass. Comparable about diabetes remission and hypertension remission and less major complication. So they conclude that sleep plus procedure may be compatible or superior with the gastric bypass in terms of the percent or excess weight loss and need a large RCT. So how to select the sleep plus procedure if you aim to perform the sleep plus procedure? You have to do 3 things. How the thicker of the visceral fat, patient have diabetes with poor control or not, severe heart disease or not. So if the patient have a thick visceral fat and concerned about the anastomosis, maybe you can do sleep plus PJB. And for the diabetes with poor control, the better outcome is for the sleep DJB and SADIs. And for the heart disease, we can do sleep plus PJB is more easier. So in conclusion, for all the modern bariatric surgery in the future should be good and simple and can reproducible with the surgical technique, improve the outcome of metabolic disease and improve overall morbidity and mortality. And don't remember about the good teamwork to get your best outcome. Thank you very much. Any questions?
Thank you for your excellent overview on sleep plus procedures. Next up, we please welcome Professor Matthew Crow, Vice Chair, Innovation and Technology, Digestive Disease and Surgery Institute, Cleveland Clinic, Ohio, the United States. He will present complications in gastric bypass procedures, early and long-term considerations.